All right, we're going to do specialized testing of the knee. There's some sort of critical tests that we definitely don't want to miss. I'm going to review those. So I'm going to go ahead and have you lay back first of all, so she's nice and relaxed here. The Lofland is probably one of the biggest ones. So the key with this one is we're really looking to see if that ACL is intact. And again, you have two extremities here, so comparing the two sides is going to be important, particularly if there's any uncertainty about your Lofland's exam. You want the patient to be relaxed, so a lot of times I'll do this, externally rotate the leg, however I can do that, and then want to get the leg to about 15 to 20 degrees where you can do your Lofland's. This is all done passively, so if the patient's contracting or anything like that, I have them relax, and then I'm stabilizing with one hand the femur, and then relative to the femur, I'm going to move the tibia. And what I can feel here is a nice band in you and not a ton of translation. So this is a very normal negative Lachman's test. And if I had any questions about it, then I can always come to the other side, do the same thing, get to about 20 degrees. She's relaxing really nicely. Again, a little bit of external rotation at the hip can help with that, and then get a very good Lachman's exam, which is very much feels symmetrical, and it's what you want to see, and it's normal. And the end point is really what you're looking at there. She has a great end point. So the example I give is as you're translating the tibia relative to the femur, you'll feel that end point from the band. And if you don't feel that end point, then that's where you have a positive exam. So that's the Lachman's. And in that same position, about 15 to 20 degrees, is where you're going to want to be testing your collateral ligaments. So MCL is one of the most commonly injured ligaments in the knee. So this is really the key to this exam. 20 degrees, stabilize the joint with your palm here, and then you're going to provide a stress here, a valgus stress, and see if that causes any pain over the MCL. And then more importantly, is the ligament integrity good? In other words, is that opening up when I do this? And she has very good ligament integrity, and she doesn't have any pain. And then when I go over to the LCL, I often like to sort of bring the leg out a little bit, be in this position where I can hold the leg, particularly in bigger, stronger folks. And you know, it just makes it easier for me to be able to do this. And then again, using my palm to really stabilize the joint on the medial side this time, and then putting in a varus load here and feeling that LCL, and number one, seeing if it causes any pain for her, which it doesn't, and then number two, seeing what level of ligamentous laxity there is. The LCL does usually have a little bit more laxity than the MCL just naturally, but it certainly shouldn't be opening up or causing pain. The McMurray's test for meniscus is one of the tougher tests to do. Highly sensitive, but it's not specific at all. A lot of other things can hurt with a positive McMurray's, so you have to take that into account. For a McMurray's test, what I usually do is grab the heel with my hand, and I have my fingers on the joint line. So it's really important from your palpation exam that you have the joint lines in your hands well, and my fingers are out peripherally where the meniscus would be in case there's clicks or clunks, or meniscus is getting extruded under my fingers. I can feel it. And then what I do is I'm going to rotate the heel towards the meniscus that I'm examining, and I'm going to put, in this case, I'm going to examine the medial meniscus first. I'm going to put her knee into valgus. I'm going to rotate the heel inwards towards the medial meniscus. I'm going to provide an axial load and go into full flexion and full extension like this, okay? And that's going to compress that meniscus, create some twisting there, and if she has a positive test, this will hurt her. And in some cases, she won't even be able to tolerate it. So when I look at the lateral meniscus, it's the similar thing except opposite. So I'm going to turn the heel outward, so rotating the tibia, and then my fingers are still in the same area, and I'm going to put her in a varus position. Again, full flexion, full extension, and making sure she doesn't have any pain or any other abnormalities as I keep my finger right over the meniscus there. And full extension is very important because a lot of torn meniscuses don't like full extension, particularly during the posterior horn. And with that, you can do the bounce test. Just try to relax your knee here. You basically are grabbing the foot or the heel in full extension, and you give it a couple of bounces. And number one, you make sure that your extension is symmetric on both sides. If you've got one side where you're limited on extension compared to the other, that could be a problem where you've got a torn meniscus that's locking out the joint. But otherwise, if I do a bounce test and she's telling me that there's pain around the joint line or the posterior part of the knee, that could also be a positive test for a meniscal injury, although it's, again, not going to be super specific. You'd have to follow that up with some more imaging. The other test here while she's laying in this position that's important to do is patellar testing. So the first thing with the patella that you can do relatively easily, and I sort of did it during the palpation exam, is called the patellar apprehension test. So you basically are going to move the patella right and left and see how much translation she has. You can document that. So in her case, 1+ both ways. And then the real question is, does this hurt her? And the reason it's called the apprehension test is if someone's had a patellar dislocation or subluxation, they actually will stop you. They'll be very apprehensive about you messing around with their patella. And that could be suggestive of someone who's had a recent patellar subluxation or dislocation. And then another test is very important with the patella because we see patellofemoral pain so commonly is the patellar shrug test. So what I do here is, again, find the patella, put my hand right above the top of the patella and have her contract her quad, make a muscle, and then relax. And I tighten up my grip a little bit right over there, and I have her do it again. So I'm sitting right on the quad tendon here, and then one more time. And what I'm asking her is if that causes any pain. So, and the reason that would cause pain is if the patellofemoral joint is aggravated underneath, the cartilage is, and we're basically sort of isolating it into the patellofemoral joint like that and compressing it in there. Patellar compression test is another name for this. Then that's a positive sign for patellofemoral irritation or chondritis or patellofemoral pain. The final test that actually is very simple in this position that's really, really important is just doing a active straight leg test to make sure that the extensor mechanism is intact, okay? So it's the extensor mechanism starts with the quad tendon, the patellar tendon, and in the case of kids, the growth plates that are at the inferior patellar pole and at the tibial tuberosity, okay? Anywhere along there you can have an injury, a significant injury, an avulsion, a tear, a fracture, and when that happens, the extensor chain breaks down. So they cannot do an active straight leg raise, okay? So I'm gonna ask her to lift this leg straight up in the air. She's able to do it, and that's all it is. And if I wanted to provide a little resistance, I can do that, get an assessment of strength, but also if that causes any pain around the area of where the extensor mechanism is. And in her case, it doesn't. Let's try this side, go ahead. Okay, good, and we can just do a basic active straight leg raise and know that everything's intact. The few patients that we've had where they may have a patellar fracture or an avulsion of the patellar tendon or the tibial tuberosity, they basically cannot do that. And that's a pretty concerning exam finding. So the Apley's test is pretty simple. The main thing is the patient needs to be laying prone in this position. Here, you're going to go to 90 degrees with the Apley's test. You're going to provide some compression, and if this already hurts them, then I'll take it easy on them, but really the test is to provide some compression and then rotate. So it's axial load and a twist, very similar to McMurray's, and in this position. And if you're asking them if that hurts them, either on the medial side or on the lateral side as I twist the tibia medially and laterally, basically internally and externally rotate it with a compressive load there. And of course I could do that on both sides. Finally, the dial test is one that we don't use that often, but there are several really important structures in the posterior lateral corner of the knee, including the lateral meniscus, the biceps femoris tendon, the arcuate ligament, the LCL, of course. And so that corner often can have injuries, and when you do, you have rotational deficits as a result. So the dial test you can look at 90 degrees, and you basically are doing an external rotation of the tibias and making sure that it's symmetric. And then you're going to come down here at 60 and then all the way down at 30 degrees, where you can then isolate the posterior lateral corner without the PCL being involved. So when you're up here at 90, the PCL is a player, but as you come down closer to 30 degrees, you can see she's symmetric in all of them, and that's what you would expect. So if you had an asymmetry like this, for example, then the concern would be that the rotary structures on the affected side have torn, and as a result she has some structural instability there, rotational structural instability that may need to be dealt with. So that's the dial test. The drawer is important because you can do an anterior and posterior drawer, another way to assess the ACL, and then of course a great way to assess the PCL. So you're going to want to sit on the foot. You see this done a lot out in sporting events and out on the field, because it's sort of one of the classic tests that are done. And the other disadvantage with the drawer test is you do have to get them to 90 degrees. So if you have someone who's acutely hurt and they can't bend their knee, again, the Lockman's perfect because you only need 15, 20 degrees to do the Lockman. And frankly, it's a more sensitive test for the ACL. But if you're going to do a drawer test, you got to be at 90 degrees, sit on the foot. So you're stabilizing everything well. Again, you want them relaxed. You're going to have your hands around the tibia and you're going to grab that tibia. And you can see where I'm grabbing right on the epiphysis of the tibia, and I'm going to do an anterior translation relative to that femur and see if that ACL is torn, the tibia is going to translate further and it's not going to have an endpoint. In her case, she has a nice endpoint, and again, I have another leg if I want to compare. For the posterior drawer, very similar. My fingers are going to be in the same place, and I'm going to push backwards. Okay, and it's a posterior translation that you're doing of the tibia relative to the femur and seeing does she have any abnormal translation there. It's really, this test is about what you feel, the translation of the tibia relative to that femur, forward in the case of anterior drawer and backwards or posterior in the case of a posterior drawer, and feeling for an endpoint. In other words, feeling that band catch as you hit your anterior and posterior translation endpoints. And if you don't have that endpoint, or there's too much translation, you may have concern for a positive test. So.